I'm Matt Hadfield. I'm a medical oncologist at Brown University in the Lagaretta Cancer Center in Providence, Rhode Island, focusing mostly on phase 1 early drug development and cutaneous malignancies. Really excited today to be joined by the Ontada team and having a really hopefully spirited and great conversation about rare cancers. This is an area that's incredibly important right now in oncology, particularly as we start moving more towards precision-driven medicine, more basket trials, more tumor agnostic FDA approvals. So really timely and important conversation. With that, I'll turn it over to my colleague, Dr. Haque, for an introduction.
Thanks, Dr. Hadfield. I'm Waqas Haque. I'm an oncology fellow at U Chicago and recently finished residency in internal medicine at NYU and clinical investigator track, and also interested in understanding more about rare disease and rare cancer specifically, and some of the things that were highlighted earlier. Before we get started, it would be great to just get a round of introductions. If I can start with Dr. Sullivan.
Thank you so much, and thanks for having us here today. We're really looking forward to it. My name is Amy O'Sullivan. I serve as Chief Research Officer at Ontada. We are a data and insights company focused on oncology. Really excited, as I said, to be here, and I'm going to turn it over to my colleague, Dr. Robert.
Hello, everyone. Nick Robert, background in medical oncology, hematology, and pathology, and I'm the Chief Medical Officer for Ontada, and I'd like to hand it over to Dr. Su.
Yeah. My name is Zhaohui Su. I'm the trained biostatistician for 25 years, working at the Ontada, VP of Biostatistics. Thank you.
Great. No, again, I'm so excited to have this conversation and to be joined by you today. I think just to sort of set the context for our conversation, maybe you could help us understand what are rare cancers and how we define them and why it's so important to keep them in mind as we consider drug development and new therapeutic options.
Let me jump into that, and then Amy will also follow up. But rare cancers, actually, when you begin to look at it, these are cancers that are less than 6 per 100,000. They now represent about 25% of all cancers, underscoring the importance of really a better understanding the natural history, the clinical course, and treatment outcomes. This is really, as you mentioned, Matt, has been instituted with the advent of precision medicine, genomic profiling, and molecular diagnostics. So studying rare cancers have undergone really a transformation. The traditional view of cancer being a singular entity has really been altered. So that now we have to appreciate that there is a collection of rare biomarker-defined subtypes of cancer, and these biomarker-defined cancers have opened new avenues for targeted therapies. However, this does provide and present significant research challenges. Amy, you may want to comment on that.
Yeah, thanks, Nick. I mean, we've been looking at this, as you know, there's an increased interest in real-world research around studying rare cancers because, as Nick said, there's been an increase in the number of cancers that we define as rare as precision medicine has increased in innovation and biomarkers have improved. So, we've seen recently, for example, an FDA study that was awarded to investigate the natural history, characteristics, and treatment outcomes associated with 10 rare cancers in the real-world setting. And I think that interest in real-world research around rare cancer continues to increase.
Thanks for sharing that. And can you talk a little bit more about some of the challenges in studying rare cancer populations so far?
Yeah, I'll jump in here as well. So lots of challenges, lots of opportunities. The challenges are really around the small patient populations, right, that are associated with rare cancers. So we sort of identify challenges across the spectrum, clinical development to screening and diagnosis, to treatment selection and patient outcomes. If I just give a couple of examples here with respect to clinical development, running clinical trials for patients with rare cancers obviously requires finding those patients with a specific biomarker, saving patient recruitment and enrollment, time-consuming and costly. It's also the case that, Zhaohui can comment on this later, but the small patient populations in these trials can make it difficult to draw causal inferences given the size of the population. In terms of diagnosis, We've been finding that access to comprehensive genomic testing might be limited, but depending on the geographic area that patients might be in, and this might lead to equity issues. For example, where cancer diagnosed, genomic testing is also really costly, again, potentially limiting accessibility for patients. And then with respect to outcomes, the challenge for physicians is that they can only give that targeted therapy if, in fact, the biomarker status is available, meaning that the patients have to be tested, and then the physician has to wait for those test results. The second challenge might be that those tumors might be genetically heterogeneous, meaning targeting a specific mutation that's identified might not be sufficient to eliminate those tumor sites. So we feel that despite these challenges, there's lots of opportunities as well.
No, yeah, thank you so much for that overview. And I think it's interesting to kind of have this conversation in the lens of what's going on in oncology right now as we're pushing more towards targeted therapies in every disease site. And as we touched on earlier, agnostic approvals now, which has really become important. And I think that dovetails off rare cancers quite a bit. Given some of those challenges with studying rare cancers where you may not have the necessarily high numbers to conduct as big of phase 3 studies and things of that nature, what methodologies are currently being used, and what are the opportunities in the future to move forward our understanding and treatment of rare cancers?
Yeah, thanks, Matt. So we have been looking at a couple of opportunities in terms of these methodologies, and I'm really excited by a few of them. One that's been gaining traction is to assemble and analyze an external control arm alongside a clinical trial, either in place of or in addition to the control arm that is in the interventional clinical trial. The external control arm is comprised of patients who are not part of the clinical study, but whose data are used to compare to those patients who are in the intervention arm. And those data for the external control arm could come from real-world databases, real-world clinical studies, real-world clinical settings, registries, for example, EMR databases, and other sources. Obviously, in a rare patient population, this could provide a lot of benefit and save time in terms of recruiting patients in trials. And then the second one I'll just highlight is it's just analyzing the data from real-world databases, so from patients in the broader population, to, again, to understand the patient characteristics, their treatments, their treatment outcomes, and long-term what the prognosis could be.
Thanks for Dr. Sullivan. And sort of one thing that I've heard for some of your answers is really about the role of biomarkers and genetic testing and pan-tumor approvals. And, in 2017, we saw the approval of pembrolizumab, right, for MMR deficient or MSI high disease, sort of regardless of where the tumor location was. So can you speak a little bit about the paradigm shift from viewing cancer as a singular entity as sort of going more into looking at it as different rare biomarker-defined subtypes?
Maybe I can jump in here. And so what you're describing is really a paradigm shift. Maybe a little older than some of you, so I remember there was a time when we had patients with lung cancer, and we divided up between small cell and non-small cell, and the treatment for non-small cell was a combination treatment that we used. And fortunately, that's changed dramatically. And now when you're faced with someone with lung cancer, especially non-small cell lung cancer, you're really beginning to deal really with a group of biomarker-defined cancers, a number now exceeding 10 plus, requiring different treatment strategies. And this is really due to the advent, as we talked about earlier, about molecular diagnostics, identifying actual biomarkers that really have fundamentally altered the landscape of oncology. It's great news, especially for our patients. This really has provided the opportunity to develop targeted therapies, which really significantly improve the outcome of patients. And looking at patients with metastatic non-small cell lung cancer, targeted therapies will improve the overall survival by greater than 1 year compared to non-targeted therapy. So this is an exciting time. But as you heard it, because took that big population of patients with non-small cell lung cancer, now subdivided into many slices. When it comes to studying them, these smaller subsets have become challenging. And as you both mentioned, basket trials is a way to get around that. It's not quite as simple as because just the biomarker doesn't dictate completely. Some biomarkers patients behave or have different outcomes depending on the milieu, the environment of that cancer and that tumor type. But all good news for patients.
Yeah, no, absolutely. It is great news that we're starting to understand more about the biology behind some of these malignancies and really teasing out new treatment options. As we start to break down cancers into different molecularly defined subsets, and particularly as we think about cancers that are more uncommon that may have commonalities with genetic alterations, what are some of the implications of this type of research, and where do you see this moving in the future?
Well, if I can jump in on that one. Ontada is very fortunate that we have an electronic medical record that represents now about 18% of new cancers seen in the United States. And we're fortunate because we have a really good clinical picture of the work that Dr. Su and Dr. Sullivan have been doing with their teams, are able to dissect and pull out information. It gives us a really good clinical picture. The other thing that's really key is we have access to the laboratory work. So we have now more and more of the genomic information piped in, so it's available for review. And not only the potential to look at patients with known biomarkers, but as mentioned earlier, with emerging biomarkers. And, one of the gaps is when you're developing a drug and you're especially looking at a new biomarker, how do these patients really behave with standard therapy or standard therapies? And we have now the ability to provide insight. So that provides a nice foundation for development of clinical trials. You need to know where you are before you want to know where you want to go. So I think leveraging our real world research in this fashion provides us that opportunity.
And it's kind of following up about sort of the real world population and access to data that your team has. Sort of what are some of the statistical tools or methods that really help you in defining and disease, especially for rare cancers?
Yeah, great question. Analyzing rare cancers poses unique challenges, as you can imagine, due to their small patient populations. Key strategies include, I'll list the three. One, ensuring proper statistical power. Two, enhancing data completeness. And three, selecting appropriate analysis methods. To increase the statistical power, researchers can utilize larger or combined data sources, extend study follow-up time, choose suitable surrogate endpoints, and employ analysis methods tailored for small sample sizes. To improve data completeness, techniques like machine learning, natural language processing, and chart abstraction by trained abstractors can extract information from medical charts. Lastly, small sample sizes may increase the risk of bias and confounding, which can affect the generalizability of results. Evaluating data representativeness and performing sensitivity analysis are essential to reducing these risks.
No, absolutely. It's interesting that we're able to use alternative methodologies to study rare cancers. And I guess kind of to round out our conversation, we're at a very interesting time right now. As we alluded to, we've had this influx of discoveries and advancements with genomically targeted therapies and our understanding of the biology. But we've also started, I think, a little bit more pragmatically about how we do clinical trials and working in the early phase space. I think, I've had a unique opportunity to see just how some of the earlier phase trials are now more targeted and provide more efficacy than they ever had in the past, where they really were just safety trials. I think they're still safety trials, but we're seeing efficacy signals early on, which is in part due to these advancements. What are you most excited about in terms of where we go next and how we advance rare cancers and thinking about all these different avenues?
I'm happy to go first. I'm especially excited to see how AI and machine learning will further enhance data completeness and data quality in rare cancer research. These techniques automate extraction and integration of data from multiple sources, ensuring more comprehensive data sets. Natural language processing converts unstructured data in medical charts into structured formats, filling in gaps and improving data completeness. Additionally, machine learning models can detect outliers and perform consistency checks, flagging potential data errors for correction. The continued advancement of AI techniques will accelerate the research in rare cancers.
And I think it's already been mentioned that in the past, we would use different chemotherapy approaches. And frankly, although we talked about different mechanisms of action, they're pretty non-specific. We're attacking any cells that were proliferating, being indiscriminate, whether it's normal tissues or abnormal tissues. And now the potential is really, once we identify the tumor at the molecular level and identify a target, we've been able to really improve treatment. And, we've had all the excitement and initially with imatinib and then other tyrosine kinase inhibitors, but the advent of antibody drug conjugates, which has opened a whole new world, and we have newer products now for HER2 disease, HER2 positive disease, even something, the entity of HER2 low, having a not so-called HER2 positive, but a little bit of HER2 is enough to be a target. So this is, I think, absolutely exciting. And then also the advent of immunotherapy, which for some of you has been around for quite a while, but wasn't around forever. And combining those different approaches have led to some very novel treatments and, more, again, importantly, success for the patients.
Yeah, I'll tag on to what Nick was saying. I think in addition to the positive implications for patients, because that's really what this is all about, right? So we are able to give patients more targeted therapy that, as Nick said, gives them better outcomes and longer term survival for and physicians as well, because now we have more tools in the toolbox for healthcare providers and can be more specific with the treatment that they're choosing for their patients. But as a researcher, I'm also excited about the continued innovations in study designs as we think through how we can really appropriately study rare patient populations, specifically rare cancers. As we said earlier, the external control arms is getting more and more favor as we think through real world disease registries and other study designs and study types that will continue to evolve. And then, of course, Zhaohui talked about the statistical methodologies, which I agree with, AI and machine learning, changes coming so quickly. I think we'll really be able to get much better understand these patient populations in the future. That's obviously what's needed to continue to improve clinical outcomes.
Thanks for sharing all that. And it's just so exciting to see a lot of this play out even in real-time settings in the clinic. I had a patient earlier this week. We had a patient who otherwise might need chemotherapy for progression of disease for their lung cancer, but now we're seeing some more ADC approvals that we're seeing in breast cancer. Now we're finding positive data for the same drugs in lung cancer. And that's just really exciting to see, to sort of spare patients of some of those toxicities and give them a sort of a glimmer of hope for future therapy options and extending life and quality of life as well. Thanks so much for taking your time to talk with us today, and really appreciate your insights.
Thanks for having us.
Thank you for the opportunity.
Thank you.